Assalamu alaikum, all the students and junior doctors. We are going to talk today about the COVID-19 ICU management. First of all, I salute all you guys who are working in such a constrained environment. In USA, we have a lot of facilities available. We have a lot of support, but you guys are working in a very harsh environment. Now we come to the medical management. So that was the logistic part, that how to save you, how to save your colleagues, how to save the nursing staff, how to save other people. And now we will go towards the medical management. This is, as I said, that COVID can affect any part of the body. It can present in any form. And that's the most dangerous thing about this COVID, because you don't know. And another thing is that sometime you feel that patient is getting better, patient looks good, patient may go home, and then they suddenly deteriorate. But one thing which really kill people is hypoxemia, and lung is on the top of all the organs where you need a medical management is lung, and we'll talk about that. Second is heart. Why heart? What happened? This COVID caused a lot of thrombosis in the body, microthrombi in the body. So that's why some people are wondering. It is even said that, is it a respiratory disease or it's a hematological disease? Because most of the pathology is happening because of thrombosis. And when there's a lot of thrombosis in the lung, it causes the PE kind of picture, pulmonary embolism kind of picture, right heart strain. And then this thrombosis can goes into the coronaries also, cause I have seen one case of acute MI, in massive inferior wall MI, come from the COVID. So, and the third is the blood that you need to pay attention. And we have reports, and I saw one case report where there was a pure arterial thrombosis in the spine. People are coming just with stroke. I have seen 2 cases when people come with stroke, no other symptoms with the COVID. And all of these things, these 4 are the primary organs where COVID attack. And through the blood, thrombosis, cytokine syndrome, we will talk about that. And at the end, when you intubate people, give them a lot of sedation, what happened? Their blood pressure drop, because they are on positive pressure, they are on sedation. And when they drop their blood pressure, they lose their renal perfusion pressure. And then what happens? The kidney goes down. And it has been said that many people may not have died because of the lack of ventilator, but many people have died because of the lack of the dialysis machine. So how we can manage in an environment where things may not be available, things may not be very sophisticated, simple hospitals, and maybe even in the rural area, how we take care of it. That's what we need to see that. So to understand that how to treat patients on COVID, there are 2 important concepts being a physician you need to understand. And if you understand these 2 concepts, this small 2 concepts, which I'm sure you all know, it would be much easier when you will go on the bedside to manage the patient if you have this foundation of knowledge in your head when you go to the bedside. One is cytokine release syndrome. And the second is microthrombosis. These 2 major things happening when coronavirus, when SARS-CoV-2 attack people. Cytokine release syndrome and microthrombosis. These are the 2 major pathology happening in human body with COVID, and that cause all the trouble. And that's how the management and that's how the treatment guide you, if you understand this thing. Let's talk about, you all know about thrombosis. I'm not going to go in detail about thrombosis. That's very, very well known, but I will give a little hint on the cytokine release syndrome. So what is cytokine release syndrome? A large number of white blood cells, including B cells and T cell, natural killer cells, macrophages, dendrite cell, they all get, whenever virus attack the body, all these inflammatory cytokines come into the play. And you see the B cell and T cell, and there is a theory, because people who are in subcontinent and who are in third world country, or who are under the English colony, Pakistan, Bangladesh, India, Sri Lanka, and Far East, some of where the BCG vaccine is very common. And that's why the BCG is protective, because BCG plays with your innate immunity with T cell. We don't know. We just think this may be true. We hope this is true. So when this inflammatory cytokines come, and I will show you one picture later on, this cytokine goes and bind with the angiotensin receptor. I will show you one picture, and it causes more cytokine production. And what happened, that cytokine comes, it causes more cytokine production, and more cytokine causes more cytokine production. That's called dysregulation. And this dysregulation becomes life-threatening because it causes hyperinflammation in the body. That's called hyperinflammation in the body, and because of the inflammation, there is vasoplagia, hypotensive shock, and multi-organ failure. So this is one thing which virus is doing, is cytokine release syndrome. It causes a massive amount of inflammatory substance coming out in the body. And second is, and because of all this, it causes the microthrombosis. And that's where your management starts. That if so many inflammatory things are coming, hopefully your hospital has this markers available beside regular labs like blood count, like electrolytes, creatinine, liver function test. I know one physician I was talking to and working on one of the paper where they are looking into the COVID direct effect on the liver. But this is your one marker which will tell you everything. Ferritin is your main acute inflammatory marker. And studies have shown that with the ferritin level, your mortality or your prognosis can be determined. If your ferritin level goes above 900, there are two studies. One study showing that if patient ferritin level goes above 900, mortality is high. Second study showed if ferritin level goes about 1300. But I have patients I had one patient who had ferritin level of 4000 and got extubated and got better. So, but a ferritin level is a very good marker. It's an inflammatory marker. So look into the ferritin level. It will give you an idea. If patient is coming, may deceive you. Patient may look very good to you. But if ferritin level is 1700, 2000, just keep in your mind that this patient may go downhill very fast. And this patient goes down very fast. You may not even sometimes have time. Ferritin level is one of the markers you like to have in your hand on the patient. Second is LDH. Cutoff point described is 245. If it goes about 245, you are going into the danger territory. CRP, C-reactive protein, cutoff point described where patient can have problem is about 100. D-dimer, it has been shown 1000, but one of the best which I have seen and I believe is double of your lab. Whatever your lab is telling you, if your D-dimer is double of it, then it means that patient is in the COVID territory. This is important, absolute lymphocyte count. Initially, when things happen in China, one thing they noticed that patients have lymphopenia. This is very interesting that patient has lymphopenia. And this is one of, even if your COVID test, nasal swab is negative, swab is negative, if you have lymphopenia and then you have a ferritin level high, very much possibility that your patient has a COVID, because this PCRs are not very sensitive. They are 70% sensitive. This is very important. I was talking to a couple of physicians who called me from Pakistan. I was talking to them, and unfortunately, interleukin 6, IL-6 is not available in Pakistan. I hope it's available because it's determined that can you give Tosi, one of the drug we will talk to the patient. If level is more than 20, the Tosi is one of the drug which is available in Pakistan. And I will tell you that when to use that medicine. So IL-6, troponin, as I said, that acute coronary syndrome can happen because of the PE, right heart strain can happen. So looking into the heart is very important. So troponin level and CPK. And again, CPK, because this patient gets so much myalgia and the cytokine storm vibrates with the level of myalgia. If patient has a lot of muscle pain, sometimes they just have significant amount of muscle pain and their CPK goes up. because this virus presents in so many forms. We don't have full grasp of this virus, that how it presents. So if CPK is high and patient is complaining of a bad myalgia, fortunately or unfortunately, I have to talk to one of the patient in Pakistan who was complaining before 2 days before his intubation that he cannot just take the muscle pain. It was that bad, and his CPK was high, and unfortunately later on he ended up on a ventilator. That's another story, but CPKs can be another thing which can guide you, which can tell you that where are you. Now here's an X-ray. X-ray is your friend. If you can do X-ray, do every third day. Now this is very interesting. The X-ray in COVID is very interesting. If you look at the first films are clear. There are some infiltrates in the right middle lobe, if you can see that. This is about in the 5th or 7th day of the COVID, 5th, 7th, 8th day of COVID. And then it gets worse. By the 9th or 10th day, this is my experience is that most of the time, right side of the chest is more affected. And you will see mostly right middle lobe. So with right lower lobe, you will initially see some right lower lobe infiltrate. And as going forward on 10th or 12th day, you will see the right middle lobe, and it gets worse. An interesting thing about is that if COVID is resolving like acute pulmonary edema, you will slowly start getting resolution of the chest X-ray also. If patient don't have superimposed pneumonia, if patient only has COVID, you will start seeing the clearing of the chest X-ray also. But if it is superimposed pneumonia, you might not see. You may see the infiltrate or lobar pneumonia. But X-ray will guide you that where your patient is going. It is every third day. That's the recommendation, not to do every day. If you can do every day, maybe good. We do every day. But if not available, do X-ray every third day, and that will tell you patient is getting worse or patient is getting better. Many studies have looked into the timeline. Usually patient on first 2 days feel little weak. First 5 when the symptoms start on 5th or 7th day. They say 14th day, but by 5th or 7th day most of the patients have symptoms. And when symptoms start, first 3-4 days they can take it. By 5th 6th day they cannot take it. They start feeling short of breath, cough, they cannot tolerate. And by the 8th or 9th, 10th day, very quickly this normal X-ray turned into this X-ray. And patient start having severe hypoxemia. Patients start having a very low oxygen saturation. And that's where patient need the support. So what's the point? The point is that cytokine syndrome from day 8 to day 14 or 15 or 16 on the depending on the patient, this is the time when patient need support. If you can wither this cytokine syndrome storm, if storm can be withered, then you can get patient, and then the storm will go away and patient will start getting better. You can look into the ferritin level. If it's getting worse, X-ray getting worse, and then they say that the first thing happened, the fever goes away, then the cough goes away, chest X-ray starts getting better, ferritin starts getting better. But from the day 8, 9 to day 14, this is something which you need to pay attention. X-ray, CT scan, extremely important. CT scan ideally should be done before coming to ICU from the emergency department. If you is available, non-contrast. You don't give contrast. If you will give contrast, you will kill kidney of patient. Non-contrast, you don't have to do contrast, and one CT scan is enough. And you can see here that how the CT scan is deteriorating day by day. Very quickly between day 8 and day 14, this happened. And the last one is the resolution. Some fibrosis state. That's one of the thing about COVID. Those people who get coronavirus, who get SARS, they all their life get some kind of fibrosis. And it would be interesting to see in next 5 to 10 years that how many of these patients get chronic lung disease or require lung transplant because of the COVID. That's why this disease is dangerous. So you have to that's why the prevention is your friend. Once people get it, it can take anything. It all depends on the genome. Some people get very sick, some people don't get sick. Don't fall into this notion that only the young people, only the old people get it and young people are safe. We have seen people in 30s, 40s, 50s, 60s, male, female. In China, they said male more. In Houston, where I work, there are more female, and definitely the obesity. One of the things which we have seen is obesity. The fat people get more because by default they are obese. Their lower lungs already have atelectasis, and when hypoxemia attack, their lungs are not good enough. That's why they say if you are lying, sit down in COVID. If you're sitting, stand up. And we will talk about that why this is important. Respiratory support, that's what we're gonna do. What is your problem? Major problem of your respiratory is hypoxemia, lack of oxygen. That's your problem, right? But good news is that these patients tolerate hypoxemia very well, even up to 85%. I have talked to physicians in New York, people 85% oxygenation, and they are still texting on their phone. But 85 is your limit. Up to 85 they can tolerate, and once it goes, patients have presented with 60%, 70% pulse off. That's really low, but up to 85% they are good. Don't freak out. If you will freak out, if captain of the ship will freak out, then what would happen to other staff? So be calm. Saturation 85%, that's okay. And your friend is oxygen. 2 liter, 3 liter, 4 liter, 5 liter, give oxygen. If you can sustain saturation at 85%, 88%, 90%, and if patient is comfortable, not tachypnic, you are good. Oxygen. On the patient. This is extremely important. Just put patient upside down. The reason is that these patients, their alveoli are still good. Their alveolar membrane are still good. So if you, what happens that when you are standing or when you are sitting, the back of your lungs are collapsed. When you put people upside down, the back of the lung open up. That's why they say that because animals don't have access to ventilator, that's why God has created all the animals in the prone position. So the lungs have more space. Prone the patient. You can keep patient prone for 16 to 18 hours, and proning is your friend. By proning, you will save hundreds and hundreds of patients. See this picture. We have patients who are lying in prone position for hours and hours on oxygen. And as I said, that you have to just ride the storm. You have to wither the storm. You have to just go with the storm from day 7, 8 to day 14, 15, 16. Those are the 6, 7, 8 days when patient goes downhill with hypoxemia, microthrombosis, and all those things. Give them more space than lung. Prone the patient. Prone the patient. Again, I'm saying, prone the patient. That will help you. And then you can use high flow nasal cannula. People were in the beginning, somebody said that there's no need to use the high flow nasal cannula. That's not right. You can use high flow nasal cannula. You put the high flow nasal cannula and put the surgical mask on it. That will help you. Just put the surgical mask over the high flow nasal cannula. And you can even use CPAP and BiPAP. I know hospitals, and I don't want to take a name of hospital because I was talking to them about patients. They are using CPAP, BiPAP. Ideally, you should have a negative pressure room. And if it's not available, then use the CPAP and BiPAP. And proper PPE. When people are on high flow nasal cannula, go with the surgical mask. With CPAP, BiPAP, go with the okay. Let me see. I have a message here. Okay. Okay, so CPAP and BiPAP, make sure that you have a proper PPE available, because when people are on high flow nasal cannula and CPAP and BiPAP, there's a chance that there is a more aerosolization in the room. So negative pressure room is better, but put the surgical mask on top of them. And as I said, negative pressure room, or if helmet is available, this is the helmet. Many places have done helmet with positive pressure. And I was told, I was involved with a couple of people, and I was told that it was not very difficult to make. Our respiratory people were available. So all these things are important. Why I'm saying, because there's a huge debate right now going on. There are huge debate going right now, and I will talk about that. Other thing is that bronchodilators, just simple, teach patient that how he can take bronchodilators or take his own nebulizer treatment. Help him. Don't do bronchoscopy unless until patient has some major problem, collapse of the lung, full collapse of the lung, even one lobe of the lung is collapsed. That's fine. Don't do bronchoscopy. You will expose yourself, and patient might not be able to tolerate it, and you might have to intubate the patient. Bronchoscopy only if needed. If you have Flolan available, use Flolan. If patient is intubated, all these patients have right heart strain, use Flolan. I'm not sure nitric oxide is available in Pakistan. I'm sure ECMO, I'm not sure if available. We do ECMO. That's why we at Tertiary Care Center, we get transfer from other places. We have 9 patients who went into heart-lung machine, and that's a very effective therapy. And we were able to, out of 9, we were able to save 7 people if ECMO available. But the question is that, should you intubate? Intubation can actually be very deleterious. Intubate the patient only if patient continue to be hypoxemic or respiratory failure despite oxygenation, high flow oxygen, even CPAP and BiPAP if you do with proper PPE in the room, or with negative pressure room, or all the precautions you take. If there is no way you can do anything without intubation, then go ahead and intubate the patient. There's a huge debate going on, and from my experience so far in United States dealing with this for so many weeks, I can tell you that late intubation, give patient all the chance. Patient may be able to ride the storm, and patient can go out of the storm healthy and alive. Intubation, because when you intubate the patient, you give the positive pressure ventilation. Already the right side of the heart is in strain. You will give further strain to the right side of the heart. You will make hemodynamic worse, renal failure, sedation, and patient will have hemodynamic collapse. So intubation, that's one thing. If this ARDS, this is not ARDS. Remember, lung chest X-ray may look like ARDS, but this is not ARDS. This is patient compliance. When you intubate these people, and if you look at the ventilator, the compliance are usually very good. Dr. Gattinoni from Italy, who is the godfather of respiratory of the ventilators, and he came up with phenotype L and phenotype P, which I will advise you to go and read on Google, very important. But these patients usually have a very good compliance. Their alveolar walls are good. It is a problem of microthrombi and cytokine storm. This is not the alveolar ARDS problem. That comes very late in the process when the alveolar membrane get damaged. So this is in the early phases. This is not ARDS. Patient is hypoxemic. The lungs are good. That's why even if they get intubated, prone them. We prone intubated patient for 16 to 18 hours. That's where we have the proning team of the nurses, and we work with them. So proning is the best friend when it comes to the respiratory support, because this patient's compliance are very good and they don't need high PEEP. If you intubate the patient and if their compliance is good, don't give them high PEEP. If you will give high PEEP, you might even cause the problem, because you will increase the thoracic pressure. They just need oxygen. Give them PEEP of 5, 7, 8, mostly the PEEP of 10, not more than that. Don't give PEEP more than 10. If their compliance goes down and then they are going in ARDS phase, then you treat it like ARDS, like low tidal volume, and then high PEEP or optimum PEEP, and all those things comes into play. Mainstay of treatment, hydration. Remember, when you have ARDS, you make people dry. So lungs stay dry and good. But here, if you will make patient dry, patient will already have thrombosis and you are drying the patient, so you will make thrombosis worse. So you have to hydrate the patient. You have to keep patient euvolemic. I'm not saying that you give so much volume that you overflood the patient, you overload the patient. No, but you have to make sure that you give good volume. CPK is your good guide. Looking at the CPK, if you put a central line and give some volume, so keep patient euvolemic. Hydration is your friend in the early phase of cytokine syndrome. That will help you towards microthrombi. So hypovolemia, don't give Lasix. Pressor, any pressor is good. Norepi, you can use vasopressin. And there's a question that should you use inotrol? If there is a right heart strain, if you can do an echo, you can take an ultrasound machine, bedside ultrasound machine, put on the chest. If right heart looks down, these patients are very tachycardic. So before you start inotrope, dobutamine, or epi, make sure, my preference would be dobutamine, because epi can itself cause acidosis, and these patients are in acidosis. So use inotrope only if you are concerned that heart has a problem. Otherwise, any pressor is good. Despite giving all this volume and patient is still hypotensive, you need to keep renal perfusion pressure. Norepi is good, vasopressin is good. Anticoagulation. All these patients should get at least DVT prophylaxis with sub-Q heparin or sub-Q Lovinox, because these patients are very prone to develop thrombosis. Sometimes, as I said, we have patients with acute stroke. We have patients with acute coronary syndrome. We have all kinds of patients just with thrombosis. And we have a very low threshold of starting a full dose anticoagulation. If we see right heart strain, we know that patient lungs have so much thrombosis that it's putting pressure on the lung. It's kind of a pulmonary embolism. We just go ahead and start full anticoagulation. Concern has been raised that if you give heparin, it can cause heparin-induced thrombocytopenia. Here we are lucky. We have Angiomax, which is ergatroban. We have those medications available, but rather than getting patient killed, the chances of hit is 5%. But if you don't treat the thrombosis, chance of patient is dying is 70 to 80%. So if you have a concern that there is a clinical signs of thrombosis, go for anticoagulation, full anticoagulation. Sedation and analgesia. If patient is intubated, give them enough sedation and analgesia, but don't give so much sedation and analgesia that they become hypotensive. And nutrition and PUD prophylaxis. We just put when patients are better, we just, with the proper PPE, nurses go there with full gear and put the NG tube. So if patient is good, some patients can take even PO. We have patients who are saturating 85% and they are in prone position, texting on their phone, and sometimes they eat even. So, but see that if they are intubated, you have NG tube there, and NG tube is easy to put, and Dobhoff tube is hard to put. So even with NG tube, you can feed the patient. And if you are not feeding the patient, make sure that you give them peptic ulcer prophylaxis. PUD prophylaxis, peptic ulcer disease prophylaxis with H2 blocker or with a PPI proton pump inhibitor. So mainstay of treatment is actually supportive. You hydrate the patient, you keep the blood pressure well so you don't lose the renal perfusion pressure. If needed, you anticoagulate the patient, you keep them calm, and you give them nutrition. That's the mainstay of the treatment. What could be the adjuvant treatment you can use? Antibiotics. A lot of these patients get superimposed pneumonia. There's no harm in giving antibiotic. Make sure if you are using zithromycin or Zithromax, you look at the QT prolongation. We have one case where patient was given so much Zithromax as an outpatient, came here and got hydroxychloroquine and went into arrhythmia. So antibiotics is your adjuvant good friend. There's no harm giving. Give a broad spectrum, meropenem or cephalosporin, give antibiotics. Steroids, if you are giving patient good hydration and patient is still requiring pressure like sepsis, you can give stress dose of steroid with 50 milligram of hydrocortisone 3 times a day. And if it's a late phase, and if your chest X-ray or your ventilator or patient is showing a sign of, because it's a cytokine syndrome, we have physicians who have done this, and I agree with them. When nothing is working for the patient, anticoagulation, patient is going downhill, nothing is getting better, patient X-ray looks horrible, patient is purely going into multi-system organ failure. I have physicians who have used steroid, Solumedrol 60 milligram Q6 in late phase, that's fine. So steroid plus minus in the early phase. Most of the studies right now are showing that don't use steroid in the early phase, but in the late phase, that's okay because nothing to lose. Rather than losing the patient, you would rather have some superimposed infection. And home medication. People are on Synthroid, thyroid replacement at home. Patients are on their medication. There is a lot of hoopla going on in the literature that what to do with the ACE inhibitor, because this coronavirus attack, we will see the picture. of the AC receptor and AC inhibitor should be stopped. No, you don't stop AC inhibitor. There is no clinical evidence that stopping AC inhibitor make patient better. So if patient is on AC inhibitor or ARBs at home, please continue that. Continue most of the home medication because their body is used to that. If they're hypotensive, naturally you're not going to use antihypertensive they're using at home. But I always mention thyroid because people forget about thyroid and people are not getting their thyroid replacement, and most of the hemodynamic problem is coming from not getting their thyroid replacement or their chronic medications. So pay attention to the home medication, extremely important. Experimental treatment. The only medicine which has shown some benefit is remdesivir, and we will talk about that remdesivir. It is an RNA virus. Remdesivir has been invented as an HIV medication because of an RNA virus. Is still in the trial, but has shown some promise in coronavirus, in the COVID, in SARS-CoV-2. We will talk about that, how it works. So remdesivir is available. I was told that it's not available in Pakistan. Talking to physicians there on and off, remdesivir is not available. And if you give remdesivir, if available, make sure it causes a lot of GI symptoms. Patient has to ride with it. This is one medicine which is available in Pakistan. And if your patient is very sick and your patient is not getting better, use this medicine, tocilizumab. We call it TOSI. And if you go to internet, there are H score and this score and that score. A lot of scores have been developed, when to give TOSI, when not to give TOSI. The simple thing, I will say that if you have IL-6 available, if your level is more than 20, use TOSI. And if you don't have, your lab does not have IL-6 available, don't worry. If patient is sick, you think your clinical judgment, you are a doctor, you feel that patient is sick enough, go ahead and give TOSI. So this is the second medicine which you have to use, but you have to be very careful because this medicine can cause liver dysfunction. So if you are using it, you need to know that you are using it when patient is really, really sick and patient may develop TOSI. Remdesivir has been said to be is more effective when you, we will talk about that, when it's in the early phase. TOSI you can start when patient is sick. Hydroxychloroquine, in the beginning, people say it's working, but now most of the studies are saying hydroxychloroquine, no, don't use it. Don't use it. And it can cause a huge prolonged QT interval. And a lot of people have died actually because taking a humongous dose of hydroxychloroquine to save themselves, buying over-the-counter hydroxychloroquine. It can cause, I have seen one case where there's a massive QT interval. Plasma exchange, immunoglobulin. Our institution was the first institution who started the trial on plasma exchange. Personally, I have not seen any benefit of plasma exchange or immunoglobulin so far. Other medications, a lot of literature out about favipiravir, even ivermectin, statins. Even I have seen studies showing that H1, H2 blocker, your Benadryl or your Pepcid or Zantac, those medications are helping. We don't know. I don't think so. But there is some literature out there. Only two medicine which is really your friend and can help you. One is remdesivir and the second is TOSI. This can help you. Remdesivir may not save your mortality, but it decreased the time. It is a very horrible. Those people who have gone through COVID, they know that they almost died. They know that they died, and it changed the perspective of life for them. So I have some friends who have gone through that, who were physicians, got sick, and they told me that how horrible it is. But remdesivir decreased that time frame of getting sick. TOSI and remdesivir, these are the two medicine you need to remember. Now, talking about remdesivir, where it works and why remdesivir should be given in the first 4 days of the sickness. If you follow the red lines with my marker, virus is coming from here. This is your S receptor. A virus get attached here. It goes through the replication phase. If you remember your virology from pathology is in 4th year, I believe. So replication, then transcription, and then translation. When all this thing happen, and when after the translation, when you have this RNA here, remdesivir comes in effect here. So this is after translation. So if you use, and then if you don't use remdesivir is not there. These are the two paths. One where the remdesivir has been used, and there is another path where remdesivir is not available. More virus go through the replication, keep going through the replication, more RNA virus, and more attack to the receptors, more cytokines, more attack, more cytokines, and this is the deadly cycle start here. But if you give remdesivir here, after the translation phase here, if you give remdesivir here, it will stop this cycle. It will stop this cycle and remdesivir will block everything. But you need to give this medicine in first 4 days. The highest number of replication happen on day 7 to day 11. So if you give remdesivir by day 4 or by day 5, if available, that is going to work for you. So, and it will decrease all this further RNA and further viral replications. TOSI is basically we are using for rheumatoid arthritis, and it is interleukin blocker. And you see that what it does. This is the inflammatory storm. Storm is happening here. TOSI comes here and it blocks the signal transduction, and it calms the inflammatory storm. It just block it. You can see that. You can see in the picture that TOSI is just blocking this. So if your interleukin level is high, this is your interleukin. So this interleukin goes and start the inflammatory storm. These are the green one. These are the interleukin. So if your interleukin level is high, or if patient is too sick, it means interleukin level is high. You can just go ahead and start TOSI, and TOSI will displace this interleukin 6 and will block the inflammation. So these are your 2 medications which can help you. Now talk about some diseases which are with the COVID. So much thrombosis is happening that it can cause a right heart strain and can fail, right heart failure. CVP is your guide. If you have an internal jugular line available, you can look at the CVP. If your CVP is going up, it means that your heart is in right strain. Or echo. Get the bedside simple ultrasound, or if you can do echo, it will tell you about the right heart strain. If there is a right heart strain, don't wait, start full anticoagulation on the patient. This is something which can kill patient. This thrombosis can cause PE. We have one patient who was taken emergently by our vascular service to the OR to put the echoes and catheter embolectomy. So thrombosis can cause a severe massive PE, and that may be cause of the hypoxemia. So you have to pay attention. Acute renal failure, when you intubate the patient, as I said before, then you may have put patient on acute renal failure and you may not have dialysis machine available. And if you go for dialysis, slow dialysis is better. Continuous renal replacement therapy, CRRT, is better. What it does, it removes a lot of cytokines. And in Europe, there is a filter available called cytoabsorb. When you put with the dialysis machine, it absorb all the cytokines and can decrease the inflammation in the body, and it can help. But you don't want your patient to go in acute renal failure. That's why late intubation, less sedation, more hemodynamic support, keep the renal perfusion pressure. But you need to think ahead of the acute renal failure maybe coming on your way. Neurological complication. We are working right now in one of the case report. Actually, I think one of my students already sent it for publication. That patient developed Guillain-Barré syndrome. This patient developed huge autonomic dysfunction. Their blood pressure at one moment they are hypertensive, other moment they are hypotensive. Very hard to manage. You don't know which way you are going. If you give fluid, they get hypertensive. If you give them some medication to lower the blood pressure, they get very hypotensive. One of the things which we have noticed in some of the patients, that their opening pressure, their MRI may be normal. Sometimes they have hemorrhagic complications there. It can present in any way. It can present as spinal thrombosis. It can present as Guillain-Barré syndrome. It can present as just encephalopathy. It can present as stroke. Very weird, neurological. So you need to pay attention for that. Encephalopathy can happen. Autonomic dysfunction. That's what I was talking. You really will be burned by this. That will really wear you out when you are taking care of this patient. Pregnancy. I will not go much detail here because it requires another full lecture, but here 2 life there, mother, baby. Important thing is that COVID is not an indication for the delivery of the baby or C-section unless until the life of the baby via monitoring. The fetal monitoring should be on all the time on this patient. If fetal monitoring is showing that baby is in distress, then you need to deliver the baby. and treat the patient. But if baby is not in distress, because this is a storm of 5-7 days, 8 days, sometimes 10 days, this storm will pass. And if baby stays okay during that time, you don't need to deliver the baby. So COVID is not your indication that somebody get COVID and you just deliver the baby. There is no sign that virus is transmitting to the baby. There is any transplacental transfer. The conclusion at the end, you have to be very vigilant about the patient. The patient can deceive you, fool you. They look good in the evening when you leave your place of work, hospital, patient look good. Next day you go and you find out that patient is already intubated and went downhill overnight. Very vigilant on that patient about their symptoms. Organ support, heart, respiratory, prone positioning, your thrombosis, your head, your kidney, and sometimes less, maybe more. As I said, that don't intubate the patient if you really don't need to. If patient can withhold that, because intubation will invite a lot of, there will be a lot of uninvited guests for you, and that would be 10 times more hard for you. So sometimes less, maybe more on this patient. And team effort. If you guys are not working as a team, if one person thinks that he can do everything, he cannot. You guys have to be organized, very organized, and that's how you need to do. So this is the 4 lessons out of this. 2 website resources. One is the, I really like this website. This is the, you can just put on Google, MGH, which is Massachusetts General Hospital, COVID-19 treatment. You can put it, this is the website there. And this is the Mass General Hospital. They have a beautiful, beautiful protocol algorithm, full algorithm there. And you can see that on table 1, what lab work you need to do, what are the risk specification, what are the recommendation, a specific population like pregnant population. And there are a lot of very well done clinical thing done there. It's from the Mass General. So Mass General Hospital. This is one website I really like. And the second one is NIH guidelines, National Institute of Health in the United States. The guidelines is pretty good. If you put in Google NIH COVID-19 guidelines, you will get it there. If you can see that they have overview, critical care, and all those things are available. If you have any question, this is my website. These are my 2 email address. You can just email me and I will try to help you out as much I can. And I will advise you, this is one of the educational website, purely educational website we do to impart the knowledge of critical care. And there is some COVID resources we have put on this website also. If you want to go there, it's called icupulse.org. If you want to go there, you can also get help from there. Thank you very much, and I really appreciate listening to me. And if anything I can do to help, again, SMC is pride for me. Anything if I can do for doctors who are from SMC, I did my house job at Jinnah Hospital. If anything I can do for that, please, please, please contact me. Thank you.